A very good afternoon to all of you, and thank you, Dr. Dinesh sir, for giving me this platform to share my experience with anterior segment OCT use. So I'll be talking mainly about the clinical applications of anterior segment OCT in cornea and refractive surgery. So we use the AIOS2025 to assess the corneal thickness and opacity to evaluate the pre-surgical and post-surgical anterior segment anatomy. For guided laser assisted cataract surgery to image intracorneal ring segments and to see the position and vault size of the phakic IOLs. And there are many more applications. I'll be showing few interesting cases also. So with AIOS2025, we can visualize almost all the layers of the cornea, starting from tear film, epithelium, Bowman's membrane. We can see all the epithelial layer irregularities, stroma, Descemet membrane, and endothelium. So we can diagnose and stage keratoconus based upon certain criteria in the central pachymetry map. This is how keratoconus looks like on the AIOS2025. So we can see the area of maximum thinning and also the location of the cone. And also we have the option of seeing the progression maps. Epithelial mapping is a newer concept which is based upon the observation that epithelium compensates for the underlying stromal surface irregularities. And it is seen as the inferior thinning corresponding to the area of thinnest cornea. And we use it to screen the area, cases of keratoconus, PMCD, as well as early detection of corneal ectasia. And in our routine practice, we use it for all the cases who are planned for trans-PRK to measure the epithelial thickness. Now, even before the epithelium is involved, we can see the disintegration of Bowman's membrane, which is seen as relative inferior thinning on the spectral domain OCT. Now, this is a case of acute hydrops. You can see very clearly that there is a disintegration of the Descemet's membrane with rolled over margins and the central stromal scarring. And this is how a demarcation line is visible, which is a direct clinical sign of corneal collagen cross-linking, and usually it appears after a month of the C3R procedure, and it tells us the efficacy of the procedure. We can also visualize intracorneal ring segments very beautifully. We can see the position and depth of the intacs. And sometimes the underlying stromal melting, if it is there few years after intact, is very clearly visible on the AIOS2025. Now, another indication of the AIOS2025 is in PTK planning. So whenever we see that there is a corneal scar, to manage that case, we need to know the depth of the scar, position of the scar. For example, this is a case, he was a 32-year-old male patient who had undergone LASIK surgery somewhere else, and the patient had paracentral scar. There was a lot of glare, and the refraction was -2, spherical with -1 cylinder, and the patient wanted repeat surgery, but the previous records were not available. We did AIOS2025 to see the depth of the scar, and you can see that the scar is involving almost the whole thickness of the flap. But if you see very clearly, then the residual stroma is good enough, so we decided to just peel off the scar, and this is 1 month post-op. The patient had sufficient corneal thickness even after surgery. With RGP lenses, till date patient is doing fine. Now, in post-refractive surgery, even the whole extent of the flap is very clearly visible on high-resolution OCT even after years of surgery, and this feature is very useful when we plan LASIK enhancements. For example, in this patient, the patient came to us 10 years after the primary LASIK surgery with a refractive error of -1.75 diaspherical, and patient wanted resurgery. Now, to plan the resurgery, we need to know that how much residual stromal bed thickness is there, whether that allows us to treat this power or not. The residual stromal bed in this case was just 265, so it's not safe to relift the flap, so we proceeded with the surface ablation. And this is how epithelial ingrowth, when we see on the slit lamp, sometimes it's very difficult to decide whether to proceed with the removal of the epithelial ingrowth or just observe the patient. But if you do AIOS2025, like for example in this patient, the extent of the epithelial ingrowth is much more than we saw on the slit lamp photograph, and there is overlying melting of the flap. So that indicates that the epithelium ingrowth needs to be removed. This is another case where in the bottom image you can see that there are a lot of epithelial nests. We remove the epithelial ingrowth by lifting the flap, And 1 month post-op, patient vision was 6 by 6, and you can see in the image that there are no residual epithelial nests left. Also, it's very helpful for the corneal surgeons to monitor the health of the defects. This is a very nicely attached defect graft with clear cornea on day 1. While in this patient, even after a week, the corneal edema was not resolving. We did AIOS2025 and there was complete detachment of the graft. Rebubbling was done, and within a day the cornea got cleared, and there's nice attachment of the graft in the upper image. Now, around 14% of the Descemet membrane detachments are not picked up on routine examination because of dense corneal edema on day 1. So nowadays, we have started managing these kind of DM detachments on microscopic integrated AIOS2025. Can you play the video, please? So in this video, you can see, this is intraoperative OCT. So you can clearly see that there is a linear Descemet membrane detachment. So here I am making side port, and we inject non-expansile SF6, and this is guided. So you know that you are going into the right plane, and you can see that as you inject SF, there is immediate reattachment of the DM membrane. So you can visualize on table only, and that prevents the patient from you need not take the patient again and again in the OT, and there itself you know that you're in the right plane and the DM has reattached. This is 1 week post-op with clear cornea. Can you please play the video once again? So this is again one interesting case of a 28-year-old female with acute eye drops. There was a lot of corneal edema in the central with stromal scarring. We are here again doing desmetopexy, which is anterior segment OCT guided. And when you inject the gas, immediately the Descemet reattaches. And all the features that are there in the acute eye drops are visible on the AIOS2025. So this is 1 week post-op with almost clear cornea, though there was still stromal scarring was persisting. Now all the femtosecond lasers, they also have real-time OCT integrated in that, and that feature is very useful when we deal with the posterior polar cataracts. Video please. So this was a case the patient has posterior polar cataract with pre-existing capsular rupture. It was visible on the slit lamp examination only. So we took up the patient for femto laser. You can see that in the femto image itself, it's very clearly visible that there is disruption of the posterior capsule. So what we can do in these cases is, when we can just increase the offset, means we can decrease the area of lens fragmentation. We are decreasing here the offset to 1000 microns, and that leaves the endonuclear cushion behind. Now that cushion is going to act as a shock absorber. It will just take the turbulence and prevent the nucleus drop. So here we take up the patient for surgery, and since the cataract was soft, it was very easy to, you can see the posterior capsule rupture that is there on AIOS2025. Once the nucleus is out, this is the endonuclear cushion, 1000 microns, that is there, that prevents the further damage to posterior capsule. We remove the cortical matter, and you can see that has increased the safety of the surgery. The posterior capsule rupture, despite posterior capsule rupture, there is no vitreous herniation. The vitreous is there, but with the intact hyaloid. So there was no need of anterior vitrectomy. We implanted 3-piece lens inside the capsular, inside the sulcus. Another application is to measure the vault size of the ICL. The vault size of the ICL is the distance between posterior surface of the ICL and anterior surface of the crystalline lens. The ideal vault size is somewhere around 250 to 750 microns. But if you see a vault like this, a very low vault, that predisposes the patient to cataract. And if the vault size is very high, then the patient is predisposed to pupillary block glaucoma and pigment dispersion. This was a case where the surgeon realized on day 1 that the ICL was upside down. So we have to take out the, this is very clearly visible on AIOS2025, and we had to take the patient to the OT, explant the IOL and re-implant the same ICL. So to summarize, AIOS2025 is essential tool not only in diagnosing but managing the anterior segment cases. It helps detect findings, structures that may be hidden in the routine investigations. And microscopic mounted AIOS2025 is an additional tool to maximize the surgical outcome in certain cases as shown in the presentation. Thank you so much.
Thank you, Dr. Hemlata. Any questions from the audience for Dr. Hemlata or from any of the panelists? So Hemlata, in your clinical practice, is there any particular situation where as a routine you plan that you have to do an anterior segment OCT before you go ahead?
So we do it in all cases of trans-PRA, PRK, because epithelial thickness is measured and the same thickness we feed in the LASIK machine. So that is the precise removal of the epithelium. And then we do it in all cases of redo surgeries of LASIK because we need to know the depth of the flap. And then we do it in Descemet membrane detachments in all cases.
And are we using the intraoperative, I mean, even without an intraoperative OCT, you could do a descemetopexy, isn't it? I mean,
chances of entering a wrong plane are there, and sometimes we have to retake the patient to the OT. So those chances are minimized. Though these days, I mean, it's more of like academic tool. We learn a lot by doing IIOS2025. It's not necessary, but there's additional tools.
Okay, so this is the bonus you get when you buy